Good morning to all the colleagues and my seniors and my juniors. So today our topic is on a brief description regarding the paraproteinemic neuropathies. So coming to the introduction, way 40 years back in around in 1980, there is a Mayo study where there is evaluation for cryptogenic neuropathies. They found that around 10% of the cases out of within 1 year, I mean, they have done the study and they found that all the cryptogenic neuropathies by that time, they have done some protein electrophoresis, and that study was done by Kelly and Dick, Peter J. Dick of Mayo Clinic, and they found that 10% of patients have some monoclonal serum protein. So that for 10% was clinically significant, and that was been in further studies in after that following studies that was confirmed that there is something like a paraproteinemia, which is being responsible for the neuropathies. So, first we will discuss about the brief structure of the protein of the immunoglobulin. So, plasma cells are mature B cells which secrete the antibodies or immunoglobulins. So, each plasma cell will each immunoglobulin will have a specific immunoglobulin. With see this right side diagram is showing a Y-shaped this thing. There is a heavy chain and short chains. They are called light chains. The antigen binding site is that is the known as the there is some called as hypervariable regions. This is known as complement determinant region. Actually, this is the site where it attaches to the antigen. So this will be changing according to the presenting antigens. So that is known as hypervariable region also, or complement determinant region. Remaining this thing will be fairly constant. So those are known as constant regions. So as we all know, they have two heavy chains and two light chains, and the class is identified by the heavy chain class IgG, A, M, D, and E. So regarding paraproteinemic neuropathies, we are concerned about IgG, A, and M. So what is known as monoclonal gammopathy? Monoclonal gammopathy is nothing but a proliferation of a single plasma clone of the any heavy chain. Single plasma clone. It could be heavy chain as well as a light chain. So this is the usual serum electrophoresis. The left side diagram is the usual normal one, where the gamma band and showing the right side with broad and small peak. This is the normal one. If there is any monoclonal proliferation, then you will get a kind of globulins were increasing. So you can get a spike in this manner. This is known as monoclonal spike, or usually this is known as the M spike. This is the same representation. So this is the red color and the blue color. The purple one is the normal one, and the below diagram is the protein electrophoresis and immunofixation. Immunofixation IFE is the diagram D, where we can qualitate the monoclonal spike. So here you can see that there is a band in the IgG and in the kappa regions. So this is IgG kappa, and the diagram E is the here more lambda than kappa. This is also immunological separation. Coming to paraproteinemic neuropathies, most of the out of all the monoclonal disorders, most of the common one is IgG in the usual population. But coming to paraproteinemic neuropathies, the most common one associated with paraproteinemic neuropathy will be IgM heavy chain, and in that 50 to 70% will have anti-nerve antibodies, which I will come briefly. And the other point is usually the if you take the age as 50 or 55 cutoff, usually when with the advancing age, the incidence of M protein will be increasing, and sometimes that association with neuropathy and monoclonal protein can be coincidental. So the incidence will be like around 3% after the age of 70. So literature says that usually 55 to 60 after that, if you get an M spike, you should be little okay, but if it is below 55, you should be wary of. You should take it pathological unless otherwise proved if it is below 55. And most commonly, this paraproteinemic neuropathy will be associated with MGS, MGUS, and sometimes the MGUS may transform into hematological malignancies. So, what are the clinical settings that we come across in the clinical settings we come across in the day-to-day practice of paraproteinemic neuropathy? So, usually during the workup of chronic peripheral neuropathies, we can get an M protein as we send sodium protein electrophoresis. Secondly, there is a patient with neuropathy who develops with known M protein. So, like hematological malignancy, say hematology patient with valence from macroglobulinemia, they can have evaluation, they can have a M protein, then we will get a consultant. Then sometimes known MGS, they can develop neuropathy. The other one is both can coexistent and along with other risk factors in the form of diabetes, vitamin deficiencies, chemotherapy, extra related, etc. So, what are the key questions here? Were what is the major determinant of the prognosis? Is it the condition of here the patient is having? Is it neurological significance or hematological significance? Which determine the prognosis. Then how should we treat? And how should we evaluate the patients with paraproteinemic neuropathy, and what is the pathophysiology? Usually, what is the pathophysiology of the nerve injury? There are different kinds of pathophysiologies which cause neuropathy in paraproteins. The usual one will be the first direct attack on the antigen, that is epitope targeted. Usually these examples will be myelin associated glycoprotein, where it's a myelin associated glycoprotein which is targeted directly by the antibody, and it is seen in IgM and DADs, which will come later. Then Canomed and MMN, we can have IgM anti-GM1 antibodies. These are all directly really targeted antibody mediated. Then coming to
because the antibodies are producing, then that's why
directly they will injure the nerve antigens.
direct protein.
Yes, MAG. MAG is directly, is an intrinsic protein of the myelin. That's what they use.
MAG and
Yes.
sulfatide.
Yes, sulfatide is the Canomed.
Yeah.
Coming to poems, there is actually not direct antigen antibody mediated, but it's a cytokine, pro-inflammatory cytokine mediated of the paraprotein. That is in poems we'll see, and direct infiltration we'll see neurolymphomatiosis, which usually associated with the Waldenstrom's macroglobulinemia, and the deposition disease, IgM deposition or AL amyloidosis, which they get deposited in different kind of organs, and systemic phenomena, systemic manifestations may develop. Then ischemic. In ischemic, inflammatory, non-inflammatory. In inflammatory, we can get vasculitic, cryoglobulinemia, etc. Non-inflammatory also, we can have in view of the excess of immunoglobulins of the monoclonal proteins, like more than 40 or 50 gram. We can syndromes. Then coming to compressive pathology, this myeloma, plasma cell expansions can cause compressive myelopathies and ligamentous infiltration in amyloid. And finally, even paraproteinemias indirectly can cause neuropathy in the form of treatment related. Usually, we'll see in myeloma, where the myelopathy will be 70% will be associated with the treatment related axonal neuropathy, and could be both axonal and demanded. Usually says bortezomib cause conduction slowing neuropathy. So anti-nerve antibodies and neuropathy. So usually there is still studies going on regarding the confirmation of the exact antibodies of paraproteinemia and neuropathy, and new antibodies are coming up. So why it is important? Because if we able to correlate correctly with the clinical phenotype, that helps in deciding of the potential treatment. Like we say, anti-MAG antibody always have found to have IgM. It is the anti-MAG is one of the extensively studied paraproteinemic neuropathy. So it can have always have IgM heavy chain phenotype. So these are the antibodies overview. So antigen, myelin associated glycoprotein, usually all, as I said before, all of the paraproteinemic neuropathies commonly will be IgM related, and MAG and sulfatide antibodies. These are all associated with GADs. And GM1, as we know, is IgM only, less commonly IgG, and that is multifocal motor neuropathy. GQ1B Miller-Fisher syndrome, and disilocil is in the canomed. So this is phenotypes of paraproteinemic neuropathy in CMC experience that is done in 2020 study. Here, this is so here in our experience, we have a fair number of cases we have taken 74. Our N is 74. Out of 74, motor sensory presentation were 56 and pure sensory were 18. Out of the pure sensory, distal sensory involvement of 10, sensory ataxic presentation is 4, and the remaining 4, everything came negative. Nerve conduction studies also came negative, so we assumed that it could be a pure small cell fiber involvement. So out of so coming to the one type of classification, we can say IgM related and non-IgM related. So in IgM related, the neuropathies which are associated with paraproteinemia usually were DADs, MGUS, monoclonal gammopathy of unknown significance, Waldenstrom's macroglobulinemia, and the new entity, recent entity, gate ataxia with late onset polyneuropathy, Gallop syndrome, and canomed, chronic ataxic neuropathy with ophthalmoplegia, IgM paraprotein, cold agglutinins, and anti-disilocil antibodies. Non-IgM associated disorders, these are the IgG and IgA related. These are myeloma, POEMS, and amyloidosis. So if we say we have a patient with unexpectedly found or incidentally found IgG and IgJ without the association of any osteosclerotic myeloma, osteosclerotic bone lesion, or myeloma or POEMS, then we can say that peripheral neuropathy is most likely to be coincidental only. But this is not the case in IgM. So coming to the each thing briefly, now I'll discuss regarding the IgM related disorders. In each, the first one will be the CIDP and monoclonal gammopathy. This is known as the CIDP-M. So out of all the CIDPs, usually around 1/5 of the cases can have this monoclonal gammopathy, and usually they say that this monoclonal gammopathy CIDP will be less responsive to the treatment like the normal idiopathic CIDP, where we'll give plasmaplex and steroids, usual this thing. So CIDP high response treatment is around 66 idiopathic, whereas compared to the monoclonal, both are demyelinating. So response to treatment is 48% of patients. Then again, high IgM related anti-MAG antibodies are indicative of less response to treatment. Coming to DADs, distal, this is actually known as the distal acquired demyelinating symmetric neuropathy. This is mostly distal sensory predominant. They can have slowly progressive, and this is also very less responsive to treatment. The characteristic feature is that there is a distal demyelination compared to the other CIDP, where you can have total. So this can be seen in electrophysiological studies by a function of terminal latency index. So the difference between CIDP will be, CIDP can have in NCS, you can have conduction block, you can have temporal dispersion along with distal latency prolongation. But in this patient who come with chronic late onset, some 70 to more than 70 years distal with some ataxia, smile, tremor, these patients, when you see the conductions, they won't find any temporal dispersion or conduction slowing, but they can have prolonged distal latencies, say 11, around 11 or 10 in the distal latencies. This was studied in our group in say, our CMC data. So the usual common one will be around distal latencies 11 and 11.5 distal latencies in this IgM related DAGs. So the terminal latency index less than 0.25, less terminal latency index indicates that will be a terminal demyelination, which can help in finding out the DADS variety of paraproteinemic neuropathy. And as I said, elevated titers of anti-MAG antibodies can be found. So usually the phenotype will be around older than 50. The patient, most of the will be males, and usually large nerve fiber are most severely affected, like vibration and proprioception mostly affected than pinprick and fold. So this is a study in a brain article which was done, especially Dalakas group 20 years back for the DADS variety. So the point what I want to make is that the DADS variety usually even of trying so many treatments, this is still not responsive to the current medications. So the mean age is around 65 in that study, and MGUS is 22, Waldenström's 3. But finally, they have all will have a disabling tremors, and the disabling kind of will be increasing in future.
All have only 20%.
Which one, sir?
20%.
Disabling tremor endpoint, they have got 20%. They went into tremor.
20%.
Yes. So the other this one slide shows that they tried so many treatments in this DADS variety: cloambisol, corticosteroids, plasma exchange, cyclophosphamide, IVIG. Out of 19 patients, only one had persistent improvement, and even and all of these treatments they have severe adverse effects out of half of the people, and mortality related to treatment out of 1/6 of the sample. So this says that DADS variety even now has no proper even stabilizing treatment as well. Our study we didn't have, sir. Our study didn't have that. That study we didn't have that. Sorry.
No new literature.
No, sir. So next time coming to that, rituximab is there, but still not FDA approved. It's somewhat promising results. So now then following that, now the new drug what we are using is rituximab. This is the phase of B cell maturation and expression of CD markers. You can see that all the flowchart out of pro B cells CD22 and last.
Just answer that question. Even now, as per current literature, is nothing that
Not confirmed, but rituximab is effective. That's what next study I'm showing. So here all the others are showing CD20 except the pro B cells and late plasma blasts. So the rituximab is anti-CD20, and this is showing some promising results in the DADS variety, but not still FDA approved. So this is anti-CD20 chimerized human murine monoclonal antibody. Even now, it was still FDA approved for only lymphomas and rheumatoid arthritis, but off-label we have been using for NMOSD, myasthenia gravis, and so many others as we know, and DADs and CIDPs. It will eliminate B cells, but pre-plasma and mature plasma cells are not affected. So circulating B cells reduction was around 98%, and IgM autoantibodies by 47%. But IgG or IgA related monoclonal protein disorders kind of like multiple myeloma, etc. This is not effective. So these are the two studies where it is showed that the rituximab. Just I'm telling that rituximab is effective nowadays. So these are the two studies.
Why is it more effective in DADS?
Yes, this is all B cell mediated direct antigen. Pathophysiology is directly antibody mediated. No, anti-MAG DADS is directly pathophysiology B cell mediated. That is direct epitope targeted. So it can work well. So these are the two studies where it is shown that rituximab is well effective for DATs, but still not approved. Though the first one is
2009, no?
yes, sir. After that, we didn't have anything. This is the old one.
Okay. The blue line is.
So yes, sir. Blue line is the rituximab used patients.
What is
The
y-axis?
INCAT.
What is y-axis?
Yes, the AB. The left side is the INCAT score, that is inflammatory neuropathy, causation and treatment log score. That is a disability score. So we can say that over the time period, the blue line is coming down. The score, the disability score is decreasing. And the other one is the time for walking, timed walking.
And what is the red one?
Red one is the control patients who are not given rituximab. So out of all this mean IgM levels, right side top diagram is the mean IgM levels, and down is the MAG antibody titers. So everything mean IgM levels also are coming down by with use of rituximab, and even IgM MAG antibody titers are also coming down. So this is an RCT. So it's significant, but not FDA approved. It's still not FDA approved. So yeah, it's showing promising results. Then this is another study in 2003 where you can see total IgM, tetanus, and total IgG. Here I want to show that it is not affected by IgG. Total IgG is the same. So rituximab doesn't work. Usually, it's less responsible for IgG mediated problems. But it's well seen near the autoantibody IgM and autoantibody.
Reduce levels of IgG only.
Yeah.
In fact, the last talk who gave so
that is IgG4.
That's why it is not work. That is the confusion.
This is the study. Yes.
How do you explain that?
That I went to.
You're saying IgG, IgM, this is monoclonal IgM or?
Monoclonal IgM as per that one I'll look up. This is the study looked at. Yes.
Monoclonal IgG or IgM and not reducing IgG.
So coming to Canomed, this is chronic ataxic neuropathy, ophthalmoplegia, monoclonal protein cold agglutinin and diacetyl. You can disilosilyl antibodies. We can assume this Canomed as a chronic variety of Miller fissures, and this is associated with usually GQ1B and other associated antibodies, IgM heavy chain, and both kappa and lambda can be present. And this has a variable response to IVIG or plasma exchange. The new entity is gait ataxia with late onset foreign neuropathy, Gallop syndrome. And here they have found that there is a monoclonal elevation of it is IgM kappa protein gallopin. So this one actually a component of white matter in the CNS. Predominantly sensor ataxic presentation and response to IVIG. 10 years in up to date. It's up to date. So brief mention of MMNCB, multifocal motor neuropathy, and monoclonal gammopathy. So usually, as we know, it is associated with GM1 antibodies, but here M protein usually is rare. But there are 2-3 studies where even this can be associated with IgM M. And there are rare case reports associated with high titers of IgM antigen antibodies. So there is another entity called as axonal paraproteinemic neuropathy, but this one can be, we can't differentiate it from the usual distal lamp-dependent motor neuropathy. And this is also associated with IgM protein, clinically similar to the idiopathic axonal neuropathy without M protein. So this doesn't have usually anti-nerve antibodies, and this can be associated with typically associated with MGUS. So as I told you before, the treatment of IgA, IgM, IgG or IgA related M protein paraproteinemias, there is still not FDA approved, but still rituximab is the one which is study. But that here study shows regarding paraproteinemic neuropathies, rituximab is slightly not responsive. And CIDP-M is treated as well as same as CIDP-I, and the plasma exchange 3 to 5 times alternate day, followed by maintenance plexus. Alternate therapies like IVIG, corticosteroids, and the database says that 1/3 of the treated patients may respond of IgG and IgA, and regarding the other things for symptomatic management. So brief hematological disorders and paraproteinemic neuropathies. And malignancies, we have brief discussion about plasma cell disorders and lymphoproliferative disorders. So peripheral neuropathy and plasma cell disorders. In that usual normal this thing is MGUS usually associate with 5% of peripheral neuropathies, but here I want to show that in poems, out of all the poems cases, 100% will be associated with peripheral neuropathy, which resembles CIDPs, and 10%, around 8% in multiple myeloma, amyloidosis even on each 20%, and cryoglobulinemia on 4 is the after the yes. So it's association with the plasma cell disorders. This is our experience in our study, CMC experience, where our patients most commonly heavy chain IgG, IgM, and IgA. Most common one is IgG. 43 patients had IgG, and light chain types were lambda and kappa, 43 and 25. So in this, even after, and secondly, the subtype classification, we have MGUS 34 and POEMS 18 patients and solitary plasmacytoma 13. So out of that, most common one is the MGUS. So here you can see that this is the association with what is the variety of the phenotype presentation of the paraproteinemic neuropathy. So IgM usually will be DADS presentation. Then the same thing MGUS, if it is IgM, DADS. If it is IgA, IgG, usually it will be a CIDP presentation and very mild axonal. Multiple myeloma, it's usually axonal. Poems, as we said, it is a CIDP presentation, mostly CIDP like phenotype. And there are small differences. I'll show you. And Waldenstrom's, usually it's axonal. Then cryoglobulinemia and amyloidosis, those are all axonal phenotypes. Coming to MGUS, most common hematologic diagnosis with monoclonal gammopathy. And this need not be of hematological significance, but this will be actually in the neurological significance. So usually hematological problems will come. They found that hematological problems will come when the monoclonal protein is more than 3 gram % plasma cells. So the criteria here is everything less than 3, less than 10. No evidence of B cell proliferative disorder, no evidence of end organ damage. So this is the diagnostic criteria of unknown significance monoclonal gammopathy. And even on long-term follow-up, 25% of patients will develop hematologic malignancies after 25 years with MGUS. So the associated malignancies, as I said, after 25 years, 1/4 of the patients can have malignancies like multiple myeloma, amyloidosis, Waldenstrom's, and lymphoproliferative like CLL. The risk of malignancies by immunoglobulin group, IgA or IgG, they can degenerate into multiple myeloma, and IgM, as we know, it would be going into Waldenstrom's macroglobulinemia. So what are the risk factors for the malignant transformation of MGUS? If we see any MGUS, usually what are the risk factors? Usually will be any associated neuropathy or high concentration of M protein, and IgM usually associated with the increased transformation risk. So they need monitoring, and increases with high bone marrow plasma cell percentage or abnormal ratios. Multiple myeloma and peripheral neuropathy. So multiple myeloma, as I said, it's IgA or IgG related. Usually the most common one is IgG kappa. And here coming to the multiple neuropathy, 8% of multiple myeloma patients can present with neuropathy. Usually it is sensory, length dependent, axonal. And usually this multiple myeloma, most of it is masked by the neurotoxicity of the chemotherapy. And as I said, they can present with compressive manifestations in the form of radiculopathies and myelopathy. So these are the neuropathic patterns of multiple myeloma without amyloid and with amyloid, because we know multiple myeloma also can be going into AL amyloidosis. So the usual one will be distal sensory, more common than motor. And when with amyloid, it can become painful with autonomic features, and the remaining will be treatment related features. So treatment emergent peripheral neuropathy is most frequent neurological complication in multiple myeloma associated neuropathy. It can affect in 65% of patients receiving chemotherapy. We should be aware of that. So difference between multiple myeloma and POEMS. So as we said, in the POEMS, peripheral neuropathy is one of the mandatory criteria. So you can take it as 100% of patients, and it resembles peripheral neuropathy resembles CIDP in POEMS, and osteosclerotic bone lesions are present in POEMS, osteosclerotic myeloma. Skin lesions, I'll come to that in next slide. Endocrinopathies, mostly it is IgA, M protein, lambda light chain will be there, and another criteria is high levels of VEGF. In multiple myeloma is axonal osteolytic bone lesions. This is osteosclerotic, and the other CRAB, hypercalcemia, anemia, bone pain will be associated. So this is the criteria for POEMS syndrome, where mandatory criteria will be polyneuropathy and monoclonal plasma, usually lambda, and you require one mandatory criteria, both mandatory criteria, along with one of the major and one of the minor. So the major will be sclerotic bone lesions and VEGF level elevation, usually more than 200 picograms. And minor criteria, systemic features, organomegalies, extravascular volume overloads, endocrine changes. So as far as the neurologic is concerned, for us, the setting for POEMS associated neuropathy will be, it could be refractory CIDP. We can see we will see come across cases refractory to treatment which are resembling CIDP presentation, having systemic features, severe neuropathic pain, which usually not present in CIDP. CIDP usually presents with numbness, but these patients will have severe neuropathic pain, and when we ask history, they can say that calf pains. And NCS CIDP, you can have all the demyelinating picture, but here you will have axonal component. This is the setting for our neurology to find the POEMS. So this one I put just to show that what is the features associated. So splenomegaly, as we all know, skin abnormalities, you can have glomerular hemangioma, hyperpigmentation. During consults, when usually we'll go, usually POEMS is very undiagnosed in the earlier stages. So by the time it comes to the neurologist, it will become totally bedbound, and it will gone. So he will become fully disabled for life. So this initial feature should not be missed. There will be skin changes, nail changes, mucolycia, and the clubbing, and all. And even 71% has pachymeningitis also here. But usually the other diagnosis is clearly, we can see clearly, and papilledema. So here we can see that they have hyperpigmentation. Hypertrichosis patients can have hypertrichosis, leukonychia, as I told, sclerodermoid changes, white nails, clubbing, and hemangiomas, usually glomerular hemangiosis. These we should keep in mind in the systemic examination. So in the appearance of neuropathy, as I said, it's very similar to CIDP. What are the differences will be NCS findings, response to treatment, which is refractory, and pain. You should keep the pain importantly. So, and compared to the usual CIDP, POEMS syndrome, the weakness per se, we can say that is more distal predominant, and they can have atrophy. Of distal atrophy can be there, and more distal predominant. but less proximal. And some literature says that usually by the presentation, there will be negligible proximal weakness compared to the distal weakness, unlike CIDP. So, and another one is the very important for us because not as a point of Poem syndrome, not as point of Poem syndrome, but for plasmacytoma, singular multiple plasmacytoma. Say you can say it is osteosclerotic myeloma. So we don't have all these skin findings and all, but still the patient comes with CIDP and is unresponsive and refractory. So you will know only that see, even IFE can be normal in 60% of osteosclerotic myelomas. So you won't understand the patient will be refractory to the treatment and nothing will come in the investigation. So here the most important one is skeletal survey. Unless you do a skeletal survey, you can't pick up a osteosclerotic myeloma. So that the main treatment is not treating the underlying CIDP, but radiation to the osteosclerotic myeloma. So here the different presentations will be singular, multiple, densely sclerotic or sclerotic rim, mixed soap bubble appearance, and in FDG you can see the lytic lesions. Then
what does that PET scan show?
PET scan shows increased uptake.
Yeah.
That I didn't put that picture.
So doing service, we often one PET.
Oh yes,
One PET.
bone PET. So here we can.
Every patient will that.
Yes, every patient. IFE, IgG lambda. So there are some hidden areas where should we look about this osteosclerotic lesions. That is skull, pelvis, sternum, clivus, and nasopharynx. And another thing, clinically practical point of view, when going to the bedside consults and all, we should keep in mind that refractory CIDPs, VEGF, anyway, we won't ask in the first time, but secondly, there can be associated thrombocytosis. We should rule out other causes for this neuropathy with thrombocytosis, fluid overload. We should be slightly aware that it is something else, could be some paraproteinemia points related. So, as I discussed, this is neuroconduction study shows here demyelinating neuropathy, but mostly it is length dependent with axonal changes in poems, unless in CIDP. Conduction block and temporal dispersion usually very less common in poems, no soral sparing, and elevated CSF protein is seen everybody and does not respond to immunomodulatory treatment usually. And usually the final treatment will be chemotherapy or stem cell based and lenalidomide and dexa. So it's a small case vignette. It's a 2020 patient. Came with 36-year-old came with complaints of burning sensation of feet for 2 years with sensory dissociation. There is mild bladder hesitancy, mild lower limb weakness, and sibling had a non-healing fracture with swelling, and father had this one.
Go back.
This one, the strong slide. So, he had more vibration and all is intact, sir, but pain and pinprick is lost. That's all.
Pain and ability is reserved.
Lost.
Body lesion.
Yeah.
Dissociative sensory loss, low limb weakness, bladder. What is so? Vibration is
Result.
pain, more like a
Small fiber neuropathy. They wanted to tell. This is the other one. So the next thing is misplaced slide. Misplaced slide. After this, I'll come back. After this slide, I'll come back to that slide. So to primary amyloidosis, this is known as AL amyloid. Usually systemic amyloidosis incidence 5 to 12 in 1 million. The most common light chain is the lambda light chain. Then the most common symptoms were fatigue and weight loss in primary amyloidosis. So regarding the paraproteinemic and neurologist point of view, we should be aware of that amyloidosis can cause infiltration of the heart and can cause cardiomyopathies. but we should be aware of cardiac autonomic neuropathy. And we should ask histories of any sudden cardiac deaths. Then secondly, renal impairments. Usually, almost 65 to 66% of amyloidotic patients will have renal impairment. Initially, they can present with only renal impairment like nephrotic range proteinuria alone, nothing without anything else, with fatigue and weight loss. So, coming to neuropathy per se in amyloidosis, they will have this is a painful length dependent neuropathy with generalized autonomic failure. So that is around 62%. And also there is even it can affect the CNS also. Amyloidosis can affect CNS parenchyma, brain parenchyma, causing seizures, encephalopathy, and even cranial nerve palsy due to compression. So this is that case. Regarding that case, the sibling had a non-healing fracture. So I want to say it's like a small fiber neuropathy with mild motor, and the sibling had a non-healing fracture with swelling. That can be also taken as a non-healing fracture. Could be some small fiber neuropathy under this context. And father had a sudden cardiac death attributed to diabetes mellitus, and after non-healing, it's just non-healing.
Fracture or ulcer?
Non-healing ulcer, non-healing fracture with swelling. That's the one we had in that old reports. We didn't have that. I was assuming it is some small fiber because of non-healing. It's not healing. Skin is an ulcer only. It is given. So the conductions, coming to conductions here, we can see that there is a conduction block in left median, and there is some conduction velocities also around 38 to 40, but distal latencies are all okay. So here we found out after doing the minor salivary gland biopsy, we had amyloid deposits, and genetic studies showed transthyretin related hereditary amyloidosis. Then this is another one where 64-year-old long-standing diabetes mellitus, long-standing for a long-standing, these conductions are fairly okay, and 7, 10, 3 and 3, and burning paresthesias of feet and bloating, these are autonomic with orthostatic intolerance, very mild motor weakness, and autonomic function test was positive, 136 to 86, and for him an IFE was is normal, and then rectal biopsy was done, which showed amyloid deposits, and IHC showed.
Decided to look for amyloid in long-standing diabetes. We will looking for this in all the diabetes.
Was there something different? In addition, normally if you see a demanding bladder in the diabetic, you will think of other.
So what's prompted them to do that? Next time I see a diabetic,
that time he had associated severe orthostatic intolerance, sir, with not. I think 2020.
Had come to gastro OPD with history of dysphagia. Okay. And then had an info with the OPD. Blood pressure recorded that as 80. So then they admitted him for evaluation. Then they noticed that every time going to the bathroom he is falling down, and
So,
then he's having significant postal hypotension. And in between he's having significant urinary symptoms also, bladder, and all that. It's a very subacute.
maintaining the severe orthostatic in the fact that
Yes.
Yes, sir.
So the severe orthostatic where we went for ahead with the amyloid this thing biopsy. So here we found that there is in IHC showed amyloid deposit, and there is a lambda in the test showing 116 elevated lambda. So here I want to say that this patient didn't have any kind of peripheral neuropathy and all, but it's an atypical with significant orthostatic symptoms. With neuropathy in elderly, you should think of other causes. Coming to lymphoproliferative disorders, there are previous studies in Italy. These are associated with neuropathy, and there are like most of the lymphomas 60-70% were associated with alternative causes. Only 10 to 13% have this anti-MAG antibodies. So here the point is usually the lymphoproliferative disorders, we don't know what is the reason, but the peripheral neuropathy is very rare. Coming to Waldenstrom's macroglobulinemia, this is also known as lymphoplasmacytic lymphoma. They will have very high IgM levels, and incidence is around 1 in 2 million and around up to 60 years. Here, regarding polyneuropathy, it can be seen in around 47% of the patients, and the various forms of neuropathy will be DADS, similar to that seen in patient with IgM MGUS. And here, out of that, anti-MAG antibodies can be present in 50% of patients, but only difference will be it is more axonal than demyelinating compared to the DADS. Occasionally, this peripheral neuropathy can be presenting as mimicking CIDP. And when less commonly, when there is a non-length dependence, we should think of vasculitic process going on in this macroglobulinemia. And here we need a mention of Waldenstrom macroglobulinemia. Sometimes when these patients in the ward with atypical features of CNS patient features, kind of cognitive difficulties or seizures, then the CNS Waldenstrom's macroglobulinemia, that is known as also known as cerebral Richter's syndrome. They tend to call it as cerebral Richter's. This is known as actually Bing-Neal variety of Waldenstrom's macroglobulinemia, Bing-Neal syndrome. That is the CNS involvement of IgM Waldenstrom's. Then coming to coexistent risk factors, as we discussed, toxic neuropathy, chemotherapy, diabetic neuropathy, and vitamin deficiencies. So we should also be aware that even our day-to-day patients, even having the usual neuropathies, paraproteinemia, if we even think of, there will be so many coexisting conditions will be there. So recommended workup will be, usual basic testing will be for a paraproteinemic neuropathies, CBCs, ESR, CRP, electrophoresis, free light chains, and immunoglobulins quantitatively. So that itself will characterize the, but that qualitatively we need to get an IFE, and for based on that, and skeletal X-ray survey is very important to show that mainly to get an osteosclerotic myeloma plasmacytoma. These are the other ancillary tests: bone marrow biopsy and fat aspiration, abdominal fat. Because if you think of any amyloidosis, and you can, I want to say that abdominal fat biopsy, so many times it can be negative. So there are patients like 3 out of the 3 biopsies, minor salivary gland got positive, and in our CMC study only, amyloid patients, we have got 3 to 4 amyloid patients. Out of them, all got abdominal fat pad biopsy negative, but one person got minor salivary gland positive, and the other 2 got rectal biopsy positive. So if you are suspecting high, suspicion is high, then better to take the minor salivary gland as well as rectal also. So this is a short proposed algorithm from our CMC experience data. So when to suspect, it's like CID, when the patient comes with CIDP like neuropathy or sensory ataxic neuropathy or refractory small fiber. So if it is the 3 this thing, then we can go ahead with the serum protein electrophoresis, IFEs, and flow cytometry skeletal survey. And following that, if we get any M protein or solitary this thing, if it is yes, if M protein, you are getting M protein, then we can do further bone marrow study to delineate that. Otherwise, if that is, if nothing is there, we have to do the nerve conduction studies. So it is fairly direct that if bone marrow plasmacytoma is more than 10 or CAP features are there, it will be going into multiple myeloma. So here we got only if M protein is S, then NCS. If it is axonal, we can suspect AL amyloidosis. In that, there, if then we have to see for any cardiac, renal, autoimmune and all, autonomic function and all. If it is demyelinating, in the skeletal survey, if there is any lesion, solitary plasmacytoma, we have to ask for biopsy. If it is IgG or IgA lambda spike, we should think of consider poems. Look for core features and VEGF assay we will send. If both of the thing, but then we can consider it's a single M spike. Then if it is not more than 10, no crab features and no other autonomic features, cardiac, renal, and even no skeletal survey is normal, and everything is normal, then fairly we can go there, we can say that it's like an MGUS and keep under follow. This is our CMC algorithm. It's fairly easy and short. So this one. So this is the spectrum of IgM and IgG. Just these slides were put to show that just the spectrum of whole spectrum of IgG and IgM. So if you got Ig paraproteinemic plus peripheral neuropathy, if it is more than 40 grams, it will be like a hyperviscosity syndrome. Then after that, NCS will give a clue. If there is a conduction velocity slowing, then IgM with conduction velocity, IgM with conduction velocity slowing, so there will be antibody mediated, whether MAG or gangliosides. So if MAG it is positive, it will be like a anti-MAG neuropathy. If MAG is negative, IgM positive conduction velocity, it is like a CIDP. And any and other gangliosides positive, then we can go to MMNCB and Canomed. But the presentations can be different. MMNCB is asymmetrical, upper limb onset, motor, reflexic kind of. Then if it is mixed axonal and demyelinating, you can have then as we initially said, it's like check with lambda and VEGF. That will go into poems. Then if it is mixed axonal demyelinating, just check for the red flags. If there is CNS involvement in a visual pattern, and then headaches, CNS patterns, psychiatric disturbances, cognitive declines with IgM, underlying IgM, then CSF to be done, and it could be a Bing-Neal variety, Bing-Neal syndrome, or neurolymphomatosis, CNS infection, CNS involvement of the paraproteinemia, or if it is pain, rash, arthritis, with all this picture, IgM picture, the systemic picture, purpura, renal features, then it could be vasculitis related to cryoglobulinemic vasculitis. And as another red flags, autonomic, as we previously described, severe autonomic failure, orthostatic, severe pain, and rapid despite treatment. Then it could be going towards amyloid. And IgM with normal NCS, IgM with normal NCS. That means it could be small fiber or patchy dermatomal. Then if it is a small fiber, again distal small fiber or distal pain temperature sensory loss, you can go for skin biopsy. Then it will be like a idiopathic axonal or IgM deposition. So this is the whole spectrum of IgM paraprotein, how we can approach through the nerve conduction studies. Then coming to IgG and IgA is the same, two light chains, no, the lambda and kappa. And if it is as usual, if it is kappa more than 50 or 40, that is hyperviscosity syndrome. Usually we will be seeing in neuro consults most of the times. And same if it is kappa, if you got a kappa paraprotein with conduction slowing, we will treat this one as a usual CIDP only. And if it is lambda, then again lambda mixed. If it is lambda and mixed, we can say it goes to poems. Then same if it is axonal, again same red flags, CNS neurolymphomatosis, because IgM we are thinking as Bing-Neal's, but so neurolymphomatosis, pain, rash, cryoglobulins, and autonomic amyloid, and crab symptoms, osteosclerotic and lytic lesions. Then it will be multiple myeloma picture. This is the spectrum of IgG paraproteinemia. So this is the whole picture. You for this thing. Now, overall, finally treatment wise, anti-MAG neuropathies or paraproteinemic neuropathies. Right now, the best drug what we'll be using will be the rituximab mostly, and hematology will be using, if it is POEMS, they will be giving lenalidomide and DEXA protocol, and POEMS AL amyloidosis, bortezomib, lenalidomide, and some other new drugs. And intravascular lymphoma and dural lymphomatosis, rituximab based chemotherapy. So this is study in 21, where is the immune mediated neuropathy, CIN, chronic immune mediated neuropathy. So here coming down, so here IgM, MGUS and anti-MAG. IgM, MGUS and anti-MAG. Here basis mild refractory and severe refractory. So for everybody, we can start with steroids and IVIG. Initially, IgM and MGUS are anti-MAG, but finally, if it is becoming refractory, if anti-MAG is becoming refractory and all, then we can give rituximab. And severe refractory, then they tried bortezomib also, which showed good results. In IgM MGUS, which is most common in our setting, usually MGUS, unless otherwise, it will be an MGUS if everything is negative. Then we can, after the usual steroid and IVIG, we can try rituximab, and cyclophosphamide is a good option in refractory cases. So last one is like the how to monitor for the progression in the newly diagnosed MGUS. So if it is newly diagnosed, we'll be keeping under. If it is an IgM only, we should be going further. If it is IgG, IgA without any other three things like POEMS, amyloidosis, MM, then it is like a coincidental finding. So repeat evaluation every 3 to 6 months, and we should be looking about the red flags like bone pain, any constitutional symptoms, because it will go degenerate into malignancy, neurologic symptoms, and bleeding, and symptoms, amyloidosis, nephrotic range proteinurias, cardiomyopathies, and any other organomegalies. If any of the red flags are present, then that will be a progression. If no progression, then annual evaluation, same with electrophoresis and flow cytometries. And if no other red flags, then if M protein is less than 1 gram, 1.5 IgG G type, then clinical follow-up with history and physical examination only. So finally it says that patient should be 6 months or 1 year to keep under follow-up with IgM spikes, and IgGA will be very less likely usually, and to look for all these grab features along that. So finally, the take-home message will be paraproteinemic neuropathies. We should keep in mind that when will be a CIDP-like presentation, which is refractory to the treatments, we should keep in mind. And usually, we will get most of the consults. You should please look for M spike, M band, and all. And then secondly, what is the treatment they have taken? How is it refractory? Then look for associated conditions. And the other important one is ask for a skeletal survey, because if it is totally florid, we can find out that it is POEMS or any other thing. But if we don't do skeletal survey, we will miss out a solitary plasma cytoma, asclerotic myeloma, which makes a big difference. That's it.